All right, so good afternoon. I'm really excited today to have Dr. Nathan Bryan with us, and we are going to talk all about nitric oxide and how it affects us ladies in menopause and postmenopause and what it means for our arterial health, our vein health as we get older. So Dr. Bryan, thank you for joining us. I know you're a very busy man these days.
Well, Linda, it's great to be with you. Thanks for having me on, and it's good to see you.
Thanks, you as well. So I just want to highlight some of the amazing things that you've done over your career so far as a young man of 54, is that correct?
51, don't
Oh,
age
I'm
me.
sorry. Don't worry, I'm still older
At
than
this
you.
stage,
It's okay.
at this stage, it
It's
doesn't
okay.
matter, right?
I'm 57. I'm still way older than you, so it's all right. I can.
Yeah.
So, anyways, but I want to just talk a little bit about what you've done. You're internationally recognized expert in nitric oxide biochemistry. You have over 20 years of research in cardiovascular and metabolic health. You've published 100 plus peer-reviewed scientific papers. You have a couple of books, different books we're going to talk about towards the end and how the listeners can get a hold of those. You have multiple US and international patents related to nitric oxide technology. You've developed nitric oxide-based supplements and diagnostic tools, and we're going to talk about the toothpaste because I ordered
Oh,
mine
yeah.
yesterday. And you are the founder and chief science officer of Numa Nitric Oxide LLC. I know you speak at a lot of conferences. You've been doing a lot of podcasts. That's how I met you at A4M, the Academy of Anti-Aging. And you have your bachelor's of science in biochemistry from the University of Texas. You're a doctor of philosophy in molecular and cellular physiology from Louisiana State. And you have your postdoctoral fellowship from the Boston University School of Medicine. Did I miss anything that you want to share?
I think that's it.
It's a lot.
It's been my life for 30 years,
I
35
tried
years.
tried to memorize it, but I'm like, I'm just going to read it. But
Yeah.
what I want to have you start with, and I'm going to pull up my questions that I prepared for you, is if you can just explain to the audience what nitric oxide is, how we make it, like what it does,
Yeah.
and then we'll get into how we turn it off and on and all those things.
Well, nitric oxide is a foundational molecule. It's what we call a signaling molecule. It's a gas, interestingly, and once it's produced, it's gone in less than a second. But during that second, it dilates blood vessels, it mobilizes stem cells, it reverses plaque deposition. It's a neurotransmitter in the central nervous system, and it's how our body kills off invading pathogens and bacteria and viruses. Prevents our telomeres from getting shorter. It activates our mitochondria, the energy producing organelles of the cell. So that's why we call it such a foundational molecule, because it does so many things. And basically everything we know about health, longevity, and wellness is dependent upon our body's ability to produce nitric oxide.
Okay, and tell us about some of the protocols you've talked about, like commercial toothpaste, mouthwashes, and then I think also proton pump inhibitors also
Yeah.
affect our production.
Well, I'll take you back 25 years, because before we started to even rationalize developing drug therapy or product technology, number one, we had to first fully understand, how does the human body make this molecule nitric oxide? And so today we know how we make it through the foods we eat, through the oral bacteria, and we make it in the lining of the blood vessels in our upper airway, the epithelial cells.
Mm-hmm.
And so we start to do things. So then the next question is, what goes wrong in people that can't make it? And then how do we correct that? So the things you touched on, like fluoride. Fluoride is an antiseptic. It's in toothpaste, it's in a lot of mouth rinses. And in the US, 73% of the municipalities in the US put fluoride in the drinking water.
Right.
And you ask yourself, why do they do that? Well, because it kills the bacteria in the pipes. So when we drink that water, or we cook in that fluoride water, or worse, we bathe in it,
Right.
it's killing the bacteria in our pipes, in our gut, in our mouth. And it's making us, causing dysbiosis and causing human disease. And then the thing with antiseptic mouthwash, whether it's fluoride-based, alcohol-based, or chemical-based, it's destroying the bacteria in the mouth that are partly responsible for producing nitric oxide. And, just like I say, there's no physician in the world today that would recommend anybody take an antibiotic every day for the rest of their life,
Right.
because of the disruption that it does on the gut microbiome. Destroys the gut microbiome, causes systemic disease. So by that exact same argument, nobody in their right mind would take fluoride in their toothpaste, would use an antiseptic mouthwash every day to destroy the microbiome, because we now know, we've published in others, that it causes an increase in blood pressure. You lose the protective benefits of exercise. It's causing erectile dysfunction. Everything known to be associated with a loss of nitric oxide can be traced back to the fluoride, the antiseptic mouthwashes, and then you also mentioned antacids, the proton pump inhibitors. Those drugs completely shut down both systems of production of nitric oxide, and very dangerous drugs. Now we know that people who had been on the PPIs for 3 to 5 years have 40% higher incidence of heart attack, stroke, and Alzheimer's, all because it's shutting down their natural production of nitric oxide.
That is amazing to me. And does your common GP, internist, doctor, or any doctor that writes a script, a GI doctor for a proton pump inhibitor, do they know this? Like, do they know this information but they do it anyways, or they don't know and they think that they're helping by reducing your acid reflux? So here, take this, but don't bother changing your diet. Maybe don't eat those foods that cause acid reflux.
No, they do, and they should do better, because if anybody, whether it's the prescribing physician or the patient, all you have to do is read the package insert. It'll show you that proton pump inhibitors cause bone loss, hip fractures, cause gastric ulcerations, calcium deficiency, B vitamin deficiency. We need stomach acid to absorb nutrients and vitamins and minerals. We need stomach acid to break down proteins into amino acids. And I think that's the basis for many foodborne allergies today that we didn't have 30, 40 years ago. But if you're admitted to the hospital in the US, regardless of the cause, whether it's trauma, whether it's influenza-like illness, whether it's heart attack or mild cognitive impairment, dizziness, the first thing they do is give you omeprazole or pantoprazole, a PPI. And we wonder why patients don't get better in the hospital. You're accelerating their disease and onset of symptoms. And so these drugs are more dangerous than the Vioxx and the Celebrex from 25 years ago. Those drugs were taken off the market because they were causing heart attack and stroke.
I remember that.
And unfortunately, these companies knew about it and didn't disclose it through informed consent or put it on the. But the PPIs are more dangerous than the COX-2 inhibitors. They should be taken off the market and completely eliminated because they're deadly. And they provide no benefit. I mean, if you have gastric reflux disease, change your diet.
Right.
Support stomach acid production. It'll eliminate the reflux.
And all those side effects that you just mentioned too, the bone loss, calcium loss. I mean, as women getting older, we're only losing those things naturally, biologically. It's just natural. So if you're using some of these drugs, you're just speeding up that process, which
That's exactly right.
is really scary. And a lot of people don't read the inserts. They just, they say, oh, I got to take this medication, and they start popping pills. And it's interesting how we still really trust our doctors. And I don't mean to throw shade on doctors, but we should have distrust in the system. It's not the doctor's fault. It's the system in which they operate. But if anybody with any sense of objectivity, if they read the package insert of any drugs that were prescribed to them, nobody in their right mind would take them. And if you just listen to the commercials from pharma on TV, a 30-second commercial is usually 20 to 22 seconds of disclaimers and side effects. It is.
People would listen to this. They would go, oh my God, I would never take this drug. But yet the US is 4% of the global population, and we take 60% of the prescribed drugs in the world. I mean, it's amazing that we have to get back to the basics of science and get rid of prescription medication and overprescribing. Look, there's always going to be a need for some drug. If I'm septic and I've got a bacterial infection, then I want an antibiotic, right? But I think we're putting a Band-Aid on things and treating symptoms rather than recognizing the root cause of the disease and addressing that.
No, totally agree. So the other thing too is, I just want to insert this, is I remember with my kids going to the dentist, God, and they would paint the fluoride on their teeth. And when I wasn't as enlightened then as I am now, but I think about all those days when, they'd go for their cleanings twice a year and they'd paint all that fluoride on, they'd make them sit there. And now I'm like, oh my God, what.
Yeah, me too. I did the same thing to my kids. And when we were kids, our parents did it to us. And that was part of it. But, I speak at a lot of dental conferences, and, I tell the dentist, you can't do things you did 100 years ago because now we know better. We didn't know about a microbiome 100 years ago or even 50 years ago. So now we have to do things to support the microbiome instead of killing the microbiome.
It is interesting when I listened to you on another podcast and you talked about how doctors, and I think you highlighted dentists too, say, well, that's just how we've always done it. And it's like, well, that doesn't, it's that might be antiquated now. There might be a new, better way to do things.
Yeah.
So I find that. Now, what about if you say you go out to dinner and you eat a little something and you're like, oh, I got a little heartburn, and you take a Tums? Is that a terrible thing if you do that, like maybe once a year or something?
No, because that's basically a buffer, right? It's sodium bicarbonate. It's an alkaline solution to buffer the acute overproduction of stomach acid. So that's much different than taking a compound that inhibits hydrochloric acid production in the pyloric cells. So we can buffer acid if you need to, but you should never inhibit its natural production from a PPI or an H2 blocker.
Right. Okay, good. It's good just to make that differentiation. All right. So what I want to ask you is nitric oxide production. How does it change for a woman, if it does, as we go through menopause? And I want to say, let's use an example of a woman that is, using maybe Crest whitening toothpaste. Maybe periodically she's using some Scope or whatever. I never use mouthwash, but Listerine is another one, I think. But there's a lot of them if you go down the toothpaste aisle. There's tons of rinses and things. But how does our nitric oxide production change as we get older or we're in menopause? Does it, like, we lose our hormones, we lose our bones, we lose our muscle? Do we make less nitric oxide as we go through menopause? And does estrogen play a role? Do nitric oxide and estrogen have a relationship?
Yes and yes. So there's two separate and distinct nitric oxide production pathways, right? So there's the one from the oral microbiome that's dependent upon the diet, that's dependent upon our oral hygienic practices, dependent upon stomach acid production. So it's a completely different mechanism of action and separate from what we call endothelial nitric oxide production, the enzyme in the lining of the blood vessels. So we'll take them one by one. So estrogen actually activates and stimulates nitric oxide production in the lining of the blood vessels. So it's called an endothelial agonist. And in premenopausal women who have adequate estrogen, estradiols, then that stimulates nitric oxide production. And so we see that at the time of menopause in women, because we know that when premenopausal women are somewhat protected from heart attack and stroke compared to their age-matched male counterparts. Right. But when they reach menopause, there's no longer estrogen. Their risk is rapidly precipitated and increased because they've lost that activation of nitric oxide by estrogen. But again, that's dependent upon the function of the enzyme in the lining of the blood vessel. So we have to maintain a functional enzyme so that estrogen, when present, can activate, stimulate, and get nitric oxide production. So that's one. Number two, and so these two pathways both provide about 50% of the nitric oxide that we normally get. And one can compensate for the other, but once you develop menopause or endothelial dysfunction and you're inhibiting the nitric oxide production from the diet and the oral microbiome, now your body is completely devoid of nitric oxide, and that's when people start running into problems. Sexual dysfunction, high blood pressure, metabolic disease, insulin resistance, and eventually Alzheimer's. So in those people who are, the worst thing you can do during menopause is to use fluoride toothpaste, to use mouthwash, and to use antacids. Because there's no vascular production of nitric oxide. Now you've completely inhibited this compensatory nitric oxide through the enterosalivary circuit, and you start to develop problems. You get high blood pressure, you start to get plaque instability. It can lead to plaque rupture, heart attack, and stroke. So we have to promote nitric oxide production, stop doing the things that are inhibiting its natural production.
So if a woman listening to this today is like, oh God, okay, I'm going to stop using Crest whitening toothpaste, which was me, but I'm glad I've got your toothpaste now. So I've been using some of the other non-fluoridated toothpaste. They're kind of, but I'm like, all right, I'm doing this for a reason, so I'm doing this. Like the blinders are on, but there's no going back. Everything's been thrown out. I've never used mouthwash, but I am guilty of using a Crest whitening toothpaste. However, if a woman stops using the toothpaste, using the mouthwash, and how soon does your nitric oxide production come back online? Is it instant or does it take some time?
Well, we published on this in 2019. We know that within 4 days of stopping mouthwash or fluoride exposure, that the microbiome completely repopulates, and we can normalize the microbiome and normalize nitric oxide production. So it's not the end of the world. If you stop today, within several days, we know 4 days, it may happen sooner, but 4 days is the soonest we looked in that 2019 published paper. But yeah, you completely repopulate the good bacteria and you start to change the ecology in the mouth, normalize pH, improve the diversity of the microbiome, enhance nitric oxide production, and we can normalize that cycle. But then I think what we have to do is also focus on the function of the enzyme. And if you're in menopause, replace that missing active estrogen. So now we can activate that vascular production of nitric oxide and prevent, this increased risk of heart attack, stroke, and vascular disease we see in postmenopausal women.
So if a woman ditches the toothpaste, ditches the mouthwash, after a few days, 4 days, her natural nitric oxide production is kind of back online, so to speak, and she's taking hormone replacement therapy, she's taking estrogen, progesterone, a little testosterone. Is she in a good place as far as, we'll talk about food in a second, but is she doing better than someone who's not doing those things?
I think so, but we have to interrogate the function of the enzyme in the lining of the blood vessels, because if you're replacing estrogen and these nitric oxide stimulants and agonists, then we have to make sure that the enzyme, when activated, can produce nitric oxide. And so there's medical devices that can look at endothelial function and look at what's called flow-mediated dilatation to see if you activate the enzyme, does it actually dilate the blood vessels and produce nitric oxide and dilate the blood vessels? Because if not, then we got to focus on what's causing the uncoupling of the NOS enzyme and then employ strategies to do that. And obviously our products recouple the nitric oxide synthase enzyme. So now if you take our products with hormone replacement therapy, you're basically getting the cardioprotective benefits of hormone replacement therapy.
And because I've used some of your supplements. Well, I have the lozenges and just bought the toothpaste. And I know you have a Beets product also. Like what is a good combination to use? Is just using the lozenges and the toothpaste enough, or is there something else?
So I think so. Look, what we try to do is, number one, if your body can't make nitric oxide, then we got to provide it for you. But then let's fix the reason your body can't make it. And the lozenge is really the perfect delivery for that, because, it takes 5 to 6 minutes for it to completely dissolve. So it's generating nitric oxide as it's dissolving. It's restoring the balance of the microbiome, and it's fixing the enzyme in the lining of the blood vessel and leading to improvement. In fact, we see about a 20% improvement in endogenous nitric oxide production within about 20 minutes of taking the lozenge. And it gets better over time. So the lozenge is really the way to go. The reason we created the Beet product is, as you're aware, especially in the athletic and performance and workout arena, Beets have become really popular since 2012.
Right.
And there was a nitric oxide connection because Beets have been shown to produce nitric oxide, enhance athletic performance, sometimes lower blood pressure. But when I begin to look on the market for Beet products and I bring them to the lab and I tested them, 99% of the Beet products on the market didn't do anything. There was no nitric oxide activity with these Beets. So consumers were being misled. Mm-hmm. I thought, okay, if people are looking for Beets because they produce nitric oxide and they want to increase their energy and athletic performance, then I have an obligation and responsibility to deliver that. So we create a product called NOBeets. We ferment the beets, so we're optimizing the nitric oxide activity. Beets are typically really high in oxalates and can cause kidney stones in some susceptible patients. So we remove the oxalates. Okay. We put in some electrolytes because most people are dehydrated at the cellular level. And we put a mitochondrial ATP, a peak ATP product in that. So we're improving mitochondrial production, improving energy production, improving cellular hydration. And we're providing a beet product that actually delivers on nitric oxide. So for me personally, I wake up every morning and take a shot of the beets. I put it in 2 to 3 ounces of water, mix it, take it as a shot. Okay. That's how I start my day. And then I do a quick workout. I do 100 push-ups and 100 squats. And that's how I start my day. And then I'll take the lozenge typically in the afternoon, sometimes a couple, depending on my workload.
Okay. Is it one or two a day with the lozenge?
The lozenge typically, because of the half-life and the pharmacokinetics and dynamics of that delivery system, usually one lozenge every 12 hours is sufficient for what we
Okay.
call maintenance.
Hmm.
If you've got a complex patient or client that has, high blood pressure, metabolic disease, exercise intolerance, they may need more. So we just have to custom tailor the dosing based upon individual demand. But I think to answer your question, the lozenge and then utilizing our toothpaste that I just launched earlier this week, because the toothpaste is really, number one, eliminating fluoride and all the things that disrupt the microbiome, but also putting things in the toothpaste that restore the normal ecology of the oral bacteria, normalize salivary pH, to lead to enhanced nitric oxide production. So I think the toothpaste, we're remineralizing teeth, restoring the balance of good bacteria, eliminating the pathogenic bacteria. So the toothpaste, along with the lozenge, I think is a perfect system
Okay.
to start and for kind of maintenance. And then hopefully, through these conversations we're having, we can start changing the conversation of people being proactive instead of reactive, right? Because medicine is reactive. People don't do something until they have a heart attack, stroke, or have some type of health crisis. But I
I know.
think you and I have to, we take preventative measures and we're proactive. And I think that's paying dividends for our health at this stage in life, right? In our
No,
50s.
absolutely. At 51, sorry. But no, I totally agree with that. And I've used, I can't wait to get toothpaste, and I've used the lozenges. I actually have several of my clients using them as well, and they love them. So, thank you for that. And I was going to bring up the beets because I know you see a lot of advertisements, commercials for chewies and gummies and this and that. And having listened to you lecture in person many times, and you've talked about how these products really don't have any, they're not doing what they say they're doing, and you're just probably ingesting dyes and colors, and they're red and all that. So what about just eating beets? What if you made beets, if you had them once or twice a week as a carb when you're having dinner or something? What about, does that help raise nitric oxide? Let's talk a little bit about foods that we can
Yeah.
incorporate every day, because I think that's important.
Well, the answer is maybe. And the reason it's maybe is because we tried to answer this question 10 years ago. We published this in 2015. But it depends upon where you live, because we went to 5 cities across the US and just measured the nitrate content of vegetables in New York, Raleigh, LA, Dallas, and Los Angeles. And there's as much as a 50-fold difference between the nitrate in vegetables in New York versus Dallas and Chicago, or Dallas and Los Angeles, for example. So they may provide enough nitrate or they may not. The other thing is you can do all the right things, eat the right diets, eat green leafy vegetables, arugula, spinach, kale, beets. But if you're using fluoride in your toothpaste, if you're using mouthwash, if you're using antacids, you've completely eliminated the nitric oxide benefit of those foods and diet. And I've had conversations with Caldwell Esselstyn and, people, vegan cardiologists and vegetarian promoting doctors who now are starting to see this, because in some of their patients that put them on a plant-based diet, and some patients get better and some patients didn't. And then the question is, well, are they using mouthwash? Are they using fluoride in their toothpaste? And then, the light goes off and they go, shit, that would completely interrupt the benefits from the diet. And so now they're starting to interrogate their patients and now finding, at least from Dr. Esselstyn, that the patients who didn't always respond to a plant-based diet were the ones who were probably exposed to fluoride in their drinking water, fluoridated toothpaste, or were using mouthwash. So now that we understand this mechanism, we can start to advise and promote these strategies that can restore the natural production of nitric oxide.
What about eating animal proteins? Does that help at all with nitric oxide production? Is there a difference between if you get more nitric oxide if you're plant-based, make the assumption that you're not using fluoride toothpaste and mouthwash? Is there a difference between an omnivore and a vegetarian or a vegan, or not really?
Well, look, there's certainly the amount of nitrate that people who eat a plant-based diet are getting much more
Mhm.
than people who eat a carnivore, because there's very little stored nitrate in muscle tissue or the meats from animals. But here's what I think. I'm not a big fan of either kind of extreme diet, straight vegan, straight carnivore. I think we need to get our nutrients from a diverse source. But I think the benefits of both, because there's pretty convincing data. I'm more carnivore, keto, and it works for me. But I think the common denominator in all those is the elimination of sugar.
Right.
Because people who are health conscious and whether they choose to be straight vegan, vegetarian, they watch what they eat and they're not drinking sugary sodas. They're not eating a lot of high glycemic index foods. And same thing with carnivore or keto. Part of the benefits of that diet is the complete elimination of sugar and simple carbohydrates that lead to an increase in blood sugar.
How does sugar affect nitric oxide? Does it have any effect on it or?
No, it's probably the most potent inhibitor of
Okay.
not just nitric oxide production, but
Hmm.
any enzymatic reaction. So sugar, or what we call glucose in the blood, as the name implies, it's a glue, right? So you've all done this. If you spill your soda or a fruit drink on the counter, come back the next day, it's sticky, right? It's sugary, everything sticks together. So when we have too much sugar in our blood, it sticks to proteins, it sticks to hemoglobin, and you can pick this up as hemoglobin A1C, which is a measure of how much sugar is bound to hemoglobin. Well, too much sugar in the body binds to other enzymes and proteins. It binds to and sticks to the nitric oxide synthase enzyme. And people who understand biochemistry know that for an enzyme to work, it has to undergo a conformational change, right? To allow this flow of electrons for biochemistry. But if sugar is stuck to a molecule, it locks it, it glues it into a conformational structure, so it can't move. And so we can't make nitric oxide. Sugar bound to hemoglobin, when it goes from the arteries to the veins, it can't undergo this allosteric transition and change in structure to offload oxygen and pick up carbon dioxide. And that's why diabetics have poor wound response and non-healing wounds and diabetic retinopathy and neuropathy, because sugar sticks to the neurons, it closes down the blood vessels and perfusion. So sugar is the enemy and it should be avoided. And with continuous glucose monitors now readily available, everybody should wear it and at least get a sense of how does their body respond to the foods they're eating. And if it causes a huge insulin or glucose spike, then don't do that again.
Yeah, absolutely. It's so important. Sugar. Talk a little bit too about alcohol consumption. I mean, I don't drink alcohol, but there are still a lot of people in my age demographic going through menopause and other stuff, and they will still drink wine at night to either help them sleep better. They think it works, but it doesn't. Just actually gives you more hot flashes and night sweats. But
well, wine particularly is high in sugar. The red wines, and so you get that. And the worst thing you can do is elevate your sugar at night before you go to bed. I think there's, again, ethanol in moderation. There's a phenomenon called ethanol preconditioning, and this has been known for 30 years. In observational studies from people who had a heart attack, and find that if they had a drink or two before they had an acute MI, there was some cardioprotection and less infarct and injury in the heart. And so we started looking at this mechanism, I don't know, probably 15 years ago. And so alcohol leads to an increase or an upregulation of an enzyme called aldehyde dehydrogenase and alcohol dehydrogenase. These are mitochondrial enzymes. So what these enzymes do is they help prolong nitric oxide signaling based on NO binding to cysteine thiols, affecting their protein structure and function.
okay.
So we think there's a connection between moderate alcohol, ethanol, and not all of them are the same, because the ethanol in wine paired with the sugar in wine, you may lose that benefit.
Okay.
But when you upregulate aldehyde and alcohol dehydrogenase, these mitochondrial enzymes, it seems to confer some cytoprotection. But I think it's moderation. Obviously, too much alcohol consumption leads to portal hypertension, liver disease, cirrhosis, and we know the consequences of that. But for me, I enjoy a scotch, with a meal or something. But I eat my last meal at 6 o'clock. I do not eat late. So if I do have a wine, I only have one glass of wine. And by the time, 4 or 5 hours later when I'm going to bed, it's completely out of my system, because we usually metabolize one drink per hour.
Okay. What are your thoughts too on women, drinking alcohol and raising her risk of breast cancer and other types of female cancers? Because that, there's a lot of information out there about that. It's one reason why I don't drink, but I also I feel like I did all that in my 20s and 30s. I'm kind of over it. I don't really need it anymore. And I like to go to bed at 9:30 and just get a really good night's sleep. And I'm not really out. I'm not hanging out in bars and doing that lifestyle anymore. That was a long time ago. But
Yeah, no, I'm with you. No, I think look, there's so many confounding factors in these what we call epidemiological studies, and any small increase in risk, I think, is meaningful. But when you have small incremental increases in risk and they all additive or sometimes synergistic, then I think it's best practices just to eliminate it. But I think again, there's a lot of things that lead to primary tumor development. We talked about it before this, and a lot of it has to do with oral hygiene and root canals and affecting the energy meridians that lead to, the voltage and different organs in the body. And, root canals disrupt that. And I think it's a primary driver of primary tumors worldwide.
Yeah, I know you have a little bit more time, but let's talk about that, because when I heard you on the Diary of a CEO, I listened to that. That was a great podcast. I sent it to a lot of people to listen to.
Thank you.
And you talked about the root canal, and I went, God, I've had two. So I definitely want to know, like, what's the issue, and then you said reverse it, but how do you do that? And there are dentists that do that.
Well, look, a tooth is a living tissue, right? It's a crystalline structure. And so again, go back to the basics. What's a root canal? You go to your dentist, obviously with a toothache, and he sees that there's a disruption in that tooth, an infection, so what he wants to do is go in there. In a root canal, they remove the nerve root in that tooth.
Right.
And then they also remove the blood supply to that tooth. And then they fill it with a composite material. So that's a root canal.
Right.
Then they send you home on an oral antibiotic, because the reason your tooth ached is because you had an infection.
Right.
So, but the dentist must have forgotten that he just removed the blood supply to that tooth, because the oral antibiotic has no blood supply to that infected tooth to kill the infection. And now there's no nerve root in that tooth to tell you that that tooth hurts from the infection. But you still have an infection. You just can't feel it. And it's an asymptomatic infection. And to look the systemic effects of that, if you look and just Google or search tooth meridian chart.
Okay.
So this goes back to acupuncture, traditional Chinese medicine. Every tooth is connected to an organ, and the teeth are like circuit breakers. And everybody knows if you trip a breaker in your house, the lights go off or the wash machine doesn't work. So what do we have to do? We have to go flip the breaker back on.
Right.
Well, a root canal tooth is a trip breaker that you can't turn back on, because the conductance and the voltage and the current through that organ system or that meridian is completely shut down. So what is cancer? Cancer is a metabolic disease. It's called the Warburg effect. It only happens in low oxygen, low pH, low voltage environments. So if you develop a primary tumor in the breast, for example, in women, then you got to figure out what's causing low voltage to that tissue. And you have to look upward and look at the teeth. And most of the time, you're going to find some infection, an asymptomatic infection from a previous root canal, or it can be from a cavitation from an extraction years ago. But the challenge is you have to do a CT scan called a 3D CT or cone beam, because most dentists are still using x-rays, and x-rays will not show the radiolucency of a mild asymptomatic osteonecrotic infection. So you have to get a CT of it and look at that. So I tell anybody, whether it's a primary tumor or metastatic disease, go to the dentist, go get a 3D CT cone beam scan and figure out what's going on here. And then most of the time you got to go to what's called a biological dentist, and they can extract that infected tooth and remove that dead tissue from the body, because again, a root canal tooth is dead tissue and there's no way to completely sterilize it. And then they'll have to go in and clean up the infection, typically using ozone gas so it can penetrate into those very small tubules in the jawbone. And then most of the time there's osteonecrosis, so you got to do a bone graft or regrow the tissue. And then, once you grow a structure that can support an implant, then typically they'll do an implant.
Okay.
But, I had this done years ago. I had a root canal from, a broken tooth when I was probably 12, 13 years old.
Oh, wow.
And so probably 10 or 12 years ago, I went to a dentist and I'd known about it. And he goes, when are we going to clean up this root canal tooth? And I go, well, let's do it. So we scheduled it, extracted it. Horrible infection. I mean, I didn't even know it. but he did a biopsy or a culture of it, and it was horribly infected. In fact, those bacteria had eaten my gum jawline all the way up into my sinuses. So for me, we had to do a bone graft, regrow the tissue, and then a permanent implant. So I said I didn't notice it, but here's what I did notice. Once I got the root canal mitigated and extracted and the infection cleaned up, I always had like a chronic kind of a dull pain going down my right shoulder. And I thought it was like, my deltoid or rotator cuff or something like that. But as soon as that tooth was removed, the pain completely went away. And now many people have said that. So it may be what you call asymptomatic, but once you get it cleaned out, you'll notice that there's certain pains that go away. And then I've seen people, with chronic metastatic disease that were sent home to die on hospice that go and get their root canals cleaned up, extracted, and, the cancer goes away. A lady, I think 13 years ago, came to me with given 6 weeks to live, sent home from MD Anderson with stage 4 metastatic colon cancer. And she had like 10 or 12 root canal teeth. I sent her to the dentist. She came back, and 6 months later, she's completely free of cancer. And 13 years later, there is no cancer in her body. And she was sent home to die. Chemo had failed her, radiation, or she didn't go radiation, thank God. But surgery, chemo failed her, and the solution was to go see a dentist.
So you're saying when you have a root canal, so the tissue, it's still infected, even though they yanked everything up. You don't feel it. You don't feel the toothache because there's no nerve there anymore. So, but it could still be an infection or some kind sitting there.
Absolutely.
Okay. Yeah. All right. So I have to look for a biological dentist. Is that what you called him?
Yeah. So there's two organizations. One's called the IABDM, International Academy of Biological Dentistry and Medicine. It's IABDM.org. And you can put your zip code in. It'll tell you who's a biological dentist in the area. And then another really good organization is IAOMT, International Academy of Oral Medicine and Toxicology. And that's IAOMT.org. But those are two really good dental organizations that know how to
do it.
One know the dangers of fluoride, know the dangers of mercury amalgam fillings.
Yeah, I've got a couple of those.
Yeah, and understand how to mitigate infected root canals.
So the first one was IABB, like boy, IABBM?
IABDM.org and IAOMT.org.
Okay, good. I'll make sure I put those in there. I'm going to definitely do a little homework on that today.
Yeah, no, please do.
When I heard that, I was like, I have to ask him about that. That's for sure. But so I guess the biggest takeaway for us ladies and anybody else that listens, even men too, is ditch the toothpaste, ditch the fluoride, ditch the mouthwash, at least as a start, right? That's a good place to start.
That's right.
And, avoid sugar as much as possible, like what we talked about. And also just be mindful.
And optimize your hormones. Optimize your hormones. We live in a toxic environment. Our food is really nutrient depleted. And so we constantly have to optimize our physiology. And that includes, replacing missing supplements and nutrients and optimizing our hormones. There's things we're exposed to that are kind of out of our control that disrupt hormone production and signaling. So we're constantly having to fine tune and optimize. But at the end of the day, it's a balanced diet in moderation, physical exercise. We have to move, optimize our nitric oxide, optimize our hormones, and we can live. There's no excuse for not living a long, healthy life free of disease.
Absolutely. Well, this was awesome. I know you have to go. We have 1 minute left, but I'd love to do this again at some point because I think there's still so many questions I would have for you. But tell us, I have obviously your older book that I got the first time I met you. But you have a new book, The Secret of Nitric Oxide, which I am in the process of receiving. But where can they get it's n101.com? Is that where you can get lozenges and the beet product?
That's for the product technology, yeah. Yeah, the Secret of Nitric Oxide's my publisher, Brick Tower Press, and Jay Bolston, and my agent, Alan Morrell. And it was a 2-year project. But in that book, I tell the entire story of nitric oxide and I kind of weave my own personal story of discovery and research and innovation into that. But yeah, you can get it at nathansbook.com or Amazon, Barnes & Noble, wherever books are sold. But I also encourage people to go to my YouTube, subscribe to my YouTube, where we'll always provide scientific education, information, awareness around nitric oxide. It's Dr. Nathan S. Bryan, Nitric Oxide on YouTube.
Okay.
Social media, Instagram, Dr. Nathan S. Bryan. So I'm searchable.
I'll put all the links too in the comments when I post this. But Dr. Bryan, thank you so much. I really appreciate it. This was great 45 minutes of a lot of really good knowledge I think that people are just not aware of. So I can't wait to get this out there so that everyone can listen to it.
Well, thank you so much and hope to see you soon.
Yeah, you as well. Have a great day.
Thank you. Bye-bye.
Bye.